This talks on compression neuropathy. You might think, well, this is boring, nothing to it. There's a lot to it. And there's a lot of patients that have compression neuropathy. And for the most part, you could say that the only compression neuropathy that's treated consistently well is carpal tunnel. So let's sit back and enjoy this little chat on compression neuropathies. I like talking about compression neuropathies. When we look at any medical problem, surgical problem, we really have learned so much from evaluating the pathology. And here we have something like compression neuropathy, which is treated as a non-biopsy problem. You just decompress it. So it's hard to really make a lot of progress in understanding it when we can't look at the histology of what we're treating. We have patients that have got carpal tunnel symptoms. They have electrical studies that are positive for carpal tunnel, and we treat them with a carpal tunnel release. But when we look at their median nerves at the time of surgery, they can look anything like that essentially beautiful, normal-looking median nerve on the far left to the really compressed nerve on the far right, where there's that proximal huge dilatation and then that flat narrowing as the nerve is compressed distally. So that the histology likely is going to look very different across those three different nerves. And if we think about it, so will be the patient's presentations, the patient's electrical studies, their sensory symptoms, and the different sensory tests that we might do. So I think it's good to keep in mind that when we're treating compression neuropathy, it's not the same thing. It's a progressive chronic problem that goes through various stages. There have been a number of animal models to look at nerve compression, and a commonly used one is the placement of a silastic band or cuff around the nerve. The technique of putting the band is to put it on loosely. If you put it on too tight, you'll get a good model of acute nerve compression, and we're not looking for that. We're looking for something that's slow and progressive. So when you look at rodent model studies and primate model studies, the histology that we see is predominantly demyelination. So you see those beautiful big axons with thick myelin on the EM study on the left, and then those giant axons on the far right with barely a rim of myelin around them. So in that situation, you'd be imagining a lot of neuropraxia, slowing of conduction velocity, and in this histology, not seeing on EM any evidence of real axonal injury. Another bit of information that we can learn from looking at the animal studies that have been done, because there's not going to be a lot of human studies, is that in a given nerve, the histopathology looks different. The areas that see the most compression will look the most abnormal. So this is a primate median nerve, and you can see that some of those axons are beautifully myelinated in the center of the fascicle, but on the periphery of the fascicle, there is loss of axons. So there's axonal loss and thinning of the myelin. These are two histological studies, one on the radial sensory nerve with 3 patients, and then one on an ulnar nerve with 1 patient. The ulnar nerve was a patient who unfortunately died in hospital, and the nerve was available for evaluation. So you can see that the histology that we're seeing on that ulnar nerve is similar, human ulnar nerve is similar to what we saw with the primate, with very thinning of the myelin and dropping out and loss of axons. In the radial sensory, one patient you can see has got Renault bodies. Those are those little pointy areas where there's whorls and bundles of tissue, and loose internal epineurium on the right, mild. And then over time, you can see In the middle panel on that radial sensory, there's some subperineural edema, thickening of the internal epineurium. And then on the far side, that radial sensory nerve is just chock full of those Renault bodies, really giving you compression from inside the nerve as well as from outside the nerve. So if we look at what's available on cadaver studies and human studies and animal studies with situations with chronic compression neuropathy, the histopathology goes from mild, moderate, and severe, just like patient symptoms do, just like the physical examination does, and just like the gross pictures of those three median nerves at the beginning of talk showed. So initially, in the animal models, there's a breakdown in the blood-nerve barrier. Then there's subperineural edema with connective tissue thickening of the internal epineurium and localized fiber axonal demyelination, which then becomes diffuse, and finally axonal degeneration. The symptoms are paralleling for sensation. It's intermittent paresthesia. Patients initially may only complain of numbness and tingling at night when they've been in awkward positions, and then persistent paresthesia, and then finally out-and-out numbness. The motor symptoms will be aching, and then weakness, and then atrophy, and progressive weakness. And physical examination, initially, you're going to be able to find positive findings in the distribution of the nerve in question with provocative maneuvers at the area of the compression. The best example or most common example would be Phelan's maneuver, where the wrist is flexed and the patient has symptoms within the minute of paresthesia and numbness, or the elbow's flexed and the patient gets numbness in the ulnar nerve distribution. Vibration and pressure thresholds will be the next thing to change. And then finally, with loss of nerve fibers, they'll actually be on the sensory side, abnormal two-point discrimination or loss of functional two-point discrimination, and on the motor side, atrophy. Another point that's important to mention is the idea of the double crush. Upton and McComas in Lancet in 1973 published this article, which for me is a classic, so controversial in the 80s and 90s, and probably there's people even now that don't believe in this double crush phenomena. Jürgen Lundberg told us there was a reverse double crush. So the crush can be, for example, cervical disc disease, making you more vulnerable to distal compression neuropathies, proximal compression issues like thoracic outlet, making you more vulnerable to distal compression neuropathies, or any neuropathic problem, diabetic neuropathy, or any of the metabolic neuropathies doing the same. This is very important because you'll have patients with multi-level areas of nerve compression. This is very important because you'll have patients with multi-level areas of nerve compression, and yet maybe none of them so bad as to cause electrical studies, none of them so bad as to be particularly responsive to surgical intervention, but all of them that can be helped with modification of the provocative positional postural issues that brought these to the fore in the first place. We'll talk more about that later. How about patient evaluation? I'm going to talk about the pain evaluation, which is really important, the tests that I typically do, and then how you'd respond to the patient when they said, I'm going to have a nerve decompression operation from you or an ulnar nerve transposition. When can I hope to get better? That's a very reasonable question for a patient to ask, and I'm going to help you work through how to answer that question. I have been using a pain evaluation scale for years, and the front face of it looks something like this. It's been modified over time. Ask the patients where their pain is, how to describe their pain, draw where the pain is, and then other questions like how much has this impacted the quality of your life? How depressed are you? How angry? How frustrated? How stressed? So both of these patients have been referred for carpal tunnel. And you can see that the drawings that these patients are providing are very different. The number of adjectives used are very different. The impact on their quality of life is different. And importantly, if you don't ask the patient to draw where their pain is, then it's your own fault, because that patient on the right-hand side has got pain everywhere. And the chances of you getting a really happy camper after doing a carpal tunnel is less likely than for the patient on the left, where it's just in the hand, and here you can see it's all over the body. Every patient that I see with upper extremity problems gets a full evaluation of carpal tunnel, cubital tunnel, median nerve forearm, radial sensory nerve forearm, Guillen's canal, thoracic outlet, muscle imbalance issues with scapular movement, Sperling's test, evaluation of shoulder tendonitis. And the reason to do this test doesn't take that long to do it, but if you have patients with carpal tunnel or cubital tunnel and you don't do this full evaluation, then they may come back to you afterwards, ignoring the fact that they're all better with the carpal or cubital tunnel surgery, but complaining about something now that you could pick up on your first examination that's going to help you to help the patient so you don't become frustrated because they're ungrateful and complaining about something else, and just realizing that it's human nature to want to get the best result they can. They're thrilled that you've made their median and ulnar nerve symptoms better at the carpal and cubital tunnel level, but they need perhaps some help with conservative management at thoracic outlet. So it's pinch and grip and 2-point discrimination. You can see I have a 10-10 line there. I also do scratch collapse testing. I'll mention a bit about that. Look for fragments, look for atrophy, and really just go through that whole examination. It's definitely worth your while. Pinch and gripper is always measured. And the provocative tests are very important, especially with those patients that have upper extremity complaints that aren't going to be solved for you just by an electrodiagnostic study. You're going to have to do some work on that yourself. So I look with the provocative tests all up the extremity. This picture I like. It's Phelan on his front steps, having his picture taken, showing his Phelan's test, and you can see his elbows flexed. So he's also winding up any cubital tunnel symptoms. So you want to neutralize any other position in the extremity that might provoke a compression problem. So the forearm's in neutral, and if you see I'm putting my fingers over the median nerve, you can speed up the response by adding some pressure. So instead of having a very long examination, within about 15 seconds, if they've got carpal tunnel and you use the Phelan's plus the pressure, you'll get a positive response. Median nerve in the forearm, I take the forearms into supination that tightens up the median nerve in the forearm, and I add some pressure just at that leading edge of the pronator teres and ask for report of symptoms. And then make note of where they report it. So if I do this and they get symptoms in the ulnar nerve, that's not a positive median nerve in the forearm compression test. Now to check for the cubital tunnel, the wrist is in neutral. So I'm not testing carpal tunnel, and the shoulders are down, so I'm not aggravating at the thoracic outlet level. And I have pressure over the ulnar nerve just at the level of the medial epicondyle. To test for thoracic outlet, you can add the pressure, and you want the arms straight up. The test where they have their elbows flexed is bringing in associated potential cubital tunnels. You don't want that. And then Sperling's test to evaluate for a cervical disc problem. Tinel's test at all provocative levels as well. And then the scratch collapse test, which we first published in the mid-2000s. I actually started studying this in 1991 when Bronson introduced it to me for the first time, and then spent some time studying with John Beck, who was a colleague of Dr. Bronson, who taught me more and knows a lot about this type of evaluation. And it's very useful for patients where they have multiple complaints, multi-level nerve compression, electrical studies, normal or not nearly as severe as with their symptomatology. It allows you to figure out all the areas that are irritable with muscle or nerve compression problems, and generally leads towards a program for conservative management. So for example, on the ulnar nerve, the nerve can be compressed at the arcade of Struthers, at the medial epicondyle, the tendinous leading edge of the FCU, or Osborne's band, Guillon's canal, the deep motor branch as it hooks around the hook of the hamate, and the antebrachial fascia just proximal to Guillon's canal. I'm going to show you a couple of videos of using this test. Okay, so I want you to, are we going? I want you to resist me, be strong as you can. Good. And now I'm just going to scratch over here in your carpal tunnel, be strong as you can. And on this carpal tunnel, as strong as you can. Put over on the lateral epicondyle, be strong, resist me. Over here on the cubital tunnel, be strong, resist me. Oh, you're not trying. Be strong, good. Now over here, be strong, good. Let's try that again. Strong, strong, be strong, good. Okay, carpal tunnel, strong. Tunnel,
This is something new that she's just recently
cubital tunnel, strong.
You know, I can
All right, now be strong.
Good.
Good.
Runs from here
Other
and
cubital.
And it affects
Strong.
those 2 fingers. And there's usually if you if you bang on this,
Good.
it'll send a shock back.
Lateral epicondyle,
Not
strong.
always, but this new
Tibial
test that
sensory,
she's
strong.
working on is another indication.
Strong. Let's try that scratch. That's gotta be good. Keep your elbows into the side, keep it straight, strong as you can. Go to the ulnar nerve here and just scratching along the ulnar nerve, rubbing along the ulnar nerve, be strong as you can. Okay, let's try the be strong. Let's try the carpal tunnel on the right side. Good and strong. Ulnar nerve on the right side. Good and strong. Ulnar nerve on the left side. Nice and strong. Oh, I can do that easily. Be strong again. Open the thoracic outlet. Strong. Take your neck back. Really extend a little more. Stay there. Be strong. For tennis elbow. Be strong. Move your neck back again. Bicipital tendonitis. Be strong. Cubital tunnel syndrome. Boom. So I've learned a lot about doing that scratch collapse test since that early video, and that is that if you use ethyl chloride, which is a short-acting spray local anesthetic, you can spray out the area where you get your first collapse. So on that gentleman, it's on the left cubital tunnel. And then you can look for the next area of irritation, and then you can spray that out, and then look for the next one. So you can figure out along the line of one nerve, or even freezing out all levels on the cubital tunnel and the ulnar nerve, then look at the median nerve. So you can get an idea about where the hierarchy is on the irritability of the nerves, and as you'll see later, on the muscles as well. There was an article published from some authors from Turkey and patients with carpal tunnel, and what they showed was that in the tissue around the median nerve in patients with carpal tunnel, there was a higher level of substance P than in patients without carpal tunnel. And when I reviewed that article, I was excited to read that and thought, that's probably or possibly how this scratch collapse works. You're touching an area where there's increased substance P and you're getting a spinal reflex to collapse. I even suggested when I reviewed that article that they might want to refer to our paper on scratch collapse. They didn't, but didn't even mention it. But I think that that was definitely the stimulus for me, using the ethyl chloride to spray out potential areas of higher substance P. So as you can see in that last video, I'm asking that patient to push hard against me. And now what I do is I say, let's just balance. You push back into my hands what I'm pushing into your forearms. The other thing I'll try to do now is only give the one stimulus. So I let go of the hand that I'm not stimulating. Lots of nuances for how to do this scratch collapse test. And really, if you don't see patients with upper extremity pain that you can't figure out, or nerve pain that you can't figure out, you don't want to waste your time on this. This is really for evaluating patients that is not are not easy to figure out, and you're not going to have someone just hand you an electrodiagnostic study and say, this is the diagnosis, go do your surgery. So we'll spray out the different levels, and there's it tells you the hierarchy as you move forward. Here's a video on this. Ulnar intrinsics must be strong here. So go to my control, plexus, and down he comes on the plexus. Plexus action. So that goes out, strong. Strong. Deep motor branch, that's where he goes down, but not the elbow. So now take out the deep motor branch. Strong. How about the ulnar nerve here? Down he goes on the ulnar nerve. So if I take the cubital out as the third area. Now strong. Let's come back and see if this antebrachial stuff is something. Yes, it is. That's the fourth. Let's freeze that out. Strong. Let's see if he's got any Struthers. Strong. And he does have a Struthers. The other thing you need to do is when you're putting that pressure, as you push on that forearm, you wait, there's almost a delayed, and then they collapse down. So you have to go through this in a pace and a rhythm where you're not doing it too quickly, because the collapses after just a slight lag delay. So there are a number of videos that we've put out on using this to evaluate patients, but you really got to work with it yourself to get your own pattern. It's very helpful though. Sensory examination. So the autonomous zone of the median nerve is the distal pulp of the index finger, the ulnar nerve, the distal pulp of the small finger, and the radial nerve in that snuff box area. The sensory tests we use are the 10 tests, 2-point discrimination, and Semmes Weinstein. Important to note the palmar-cutaneous branch of the median nerve, because it'll be normal in patients with carpal tunnel, but abnormal in patients that have median nerve in the proximal forearm. And also a little later when we do carpal tunnel, you'll see I make my incision in the watershed area between the ulnar nerve palmar-cutaneous branch and the median nerve palmar-cutaneous branch. The 10-10 test was described by Barish Strauss, and when he described it, I thought it was silly. At that point, we were working on sort of ever more complicated ways to measure sensation. It's a great test. So just like we would use a 10 VAS scale for pain, then you can use that 10 test for normal sensation. So you'll say to the patient, for example, if you identify a normal finger, call that 10. 10 out of 10 is normal, 0 to 10 is nothing, 5 out of 10 is half, and then you stroke the symmetrical opposite digit, and you try not to have movement on the digit. So I've got his hands flatten his lap, and you move just in the distal pulp from the DIP crease distally and ask them to tell you what their sensation is. Someone might come in after carpal tunnel and say, whoa, I'm really numb in my ulnar nerve. And when you do the 10-10, it's like 9 out of 10. Well, it makes you feel more relieved, and the patient to some degree as well. So it's a quick way. And then 2-point discrimination, again, moving from the DIP joint distally, just enough pressure to have them give you a response, and establish initially that they can feel 1 versus 2. If they say or move the finger towards the device, that means they're wanting more information. You're getting closer to their threshold. If they give you an answer like 3, then they don't know the test. So there's nuances to doing this 2-point as well. Semmes Weinstein monofilament testing, your hand therapist will do for you. And this is a nice test to have if you have someone who is going to take a long time to get sensation back. It's encouraging for them because the therapist color code the sensation as it recovers, so they can go from red line / nothing and move towards normal sensation over time. So it's a nice test to do to follow sensation, and it's good for the patients because they can see progress as in axonal regeneration. It can be slow. Speaking of which, let's talk about the rate of recovery. So patients will say, okay, ready to sign that consent for these nerve decompression operations, but when can I expect recovery? And really how I answer it is I say to them, well, when a nerve is compressed, 3 different things can happen. It can lose blood flow, and that is fixed as soon as we do the decompression or transposition. The other thing that can happen is the axon becomes demyelinated, the plastic around the wire goes, and that can take up to 3 or 4 months to remyelinate. The third thing is the nerve fiber itself, the wire within that construct is injured, and that is slow regeneration, an inch a month, a millimeter a day. And there is often a combination of all 3 things going on, and we really don't know how much of any of them is at play. Certainly, good to mention that demyelination will be picked up by prolonged latency, slowing of conduction velocity. Amplitude is going to tell you how many nerve fibers are present. And when you're looking at cubital tunnel, you really want to pay attention to that because you can see really profound slowing of conduction across the elbow. But if the amplitude's still normal-ish, then that's a very different situation than if you have very decreased amplitude. And of course, on the motor side, axonal injury will be reflected with fibrillations. So you can say if it's mostly just waking up at night, then that's dynamic ischemia. The nerve studies may actually be fairly normal. That should get better fast. I'll get electrical studies on all patients that I'm going to do a compression, decompression operation or transposition because I want that to baseline. So if they're very mild changes, I expect rapid improvement. If there's a lot of demyelination, I tell a patient nothing much is going to happen for 3 or 4 months, and then you'll get a bounce up in recovery. And then if there's axonal injury with decrease in the amplitude, fibrillations present, then that means it's going to be a slow progress as the nerves slowly regenerate. And often there'll be a combination, so it'll be a bit of a bumpy time as far as figuring out the recovery.